Good afternoon. Welcome, everybody, to today's webinar. My name is Marcella McGuire. I'm with Corporation for Supportive Housing. We're really excited you've chosen to take some time out of your busy days in order to join us for this webinar. And we're beginning a webinar series. This is sponsored by, and I'd like to thank Noelle Porter from the National Alliance to End Homelessness and Barbara DiPietro from Healthcare for the Homeless. Noelle, I think you're on the call. Welcome. And Barbara's trying to join in. She's having trouble with the web link, but she should be in shortly. So welcome, everyone. Thank you for joining us. This is a 5-part series. This is primarily educational in nature. We are recognizing the changes that are coming, and we'll talk about that shortly, changes that may be coming in Medicaid in relation to state changes and the need for some of the most important discussions and conversations happening at the state level. We feel that it's really, really important to educate folks who are engaged in work to end homelessness, work to expand capacity supported housing, work to sustain supportive housing and supportive services for vulnerable populations, and health centers and healthcare for the homeless populations projects, health centers, primary care centers as well, that work with vulnerable populations. We really believe that the conversation is going to get, very deep, very policy wonky, very quickly, and we want to make sure that the advocates and folks that are engaged in this population understand that conversation and have the support that they need. We're doing this in 30-minute blocks. This is very dense information, and we thought that this was one of the best ways to get some of this information across to people. We also, on the webinar, will not be doing Q&A, but we will be sending out, I will be putting my email in the chat box, or Tim, if you don't mind putting that in the chat box for us. We will, please, if you've got questions that come up from the webinar, please send me the questions, and then we'll be organizing all of the questions, summarizing it, and sending it out to all of the individuals who signed up for the webinar. We know that with these, very dense, very policy and detailed-oriented conversations as well, it often becomes, you have a question a day or two later, you've now thought through what the implications are this for the people you work with, for the program you run and serve, for the system you manage, and it's like, oh, but it's too late to ask the question. No, it's not. So please, please send us your questions over the next 2 weeks, and we'll make sure that we send those answers out to you before the next webinar. So again, today, start the webinar, 30 minutes on. We'll be doing this every 2 weeks for the next 5 weeks, Monday afternoon, 1 o'clock Eastern time. And I will be starting with the first two. National Alliance and National Healthcare for the Homeless Council will be joining us, will be primary presenters for the second, third, fourth, and fifth ones. And we'll see what the response is. Also would love to hear, this is helpful, this is a great way for you to get this information, and we'll see what conversations are going on, because as we've learned over the last couple of weeks, healthcare is complicated. Healthcare is also a fast-moving target, and it'll be important to see what those targets are. So I'm going to move this. Why are we doing this? Why are we thinking this through? Really important key decisions are going to be coming at the state level around healthcare. Folks are probably very well aware that about 2 Fridays ago, I believe at this point, a little more than 2 weeks ago, the Republicans in Congress called off the American Health Care Act. They didn't bring it to a vote. They didn't have the support that they needed. And while a lot of conversations are happening in regard to that in Washington, they don't really seem to have a clear path forward. If they move the bill to a more conservative nature, they'll lose people on the left. If they move the bill to a more moderate Republican concern, they'll lose people to the right. There's really not a clear path forward for that. There'll be a lot of conversations, but we don't see that moving forward quickly at this time. It's important to know that the Republican strategy was what they talked about with a 3-pronged strategy. Prong 1 was pass the AHCA, which I just talked about where that was. Prong 2 is regulatory reform, which is something that can move forward. Will primarily move forward at the state level. Dr. Price is our Secretary of Health and Human Services. Seema Verna is our Medicaid Center for Medicaid and Medicare and Medicaid Services Director. So there are a variety of proposals proposals that states could put forward. There are a variety of incentives that the federal government could put forward as well, but a lot of this work will be shifting to the state level. So it's going to be really important that coalitions engage at that state level and know who they're engaging with. There are a variety of avenues to engage with your state Medicaid agency. We want to make sure that folks are educated around those avenues, are aware and know how to do that. We want to make sure that folks have the policy details, that they know the questions they should be asking, that they understand the language and are ready to have that conversation. And the decisions that are made at the state level will have enormous impact on the people you serve, on the programs you run, and what your communities are able to do in a response to addressing the needs of people experiencing homelessness and extreme poverty, people with extreme significant health care needs, a high cost, high need, or a complex care population. These decisions will be made, a lot of these decisions will be made at the state level, and it's going to be really important to be able to engage at the states around health care related issues. I will move on to the next slide. There we go. Just a quick primer for everyone, just to remember that the Medicaid program is operated at the state level. It's an agreement between the federal and the state governments. At the federal level, it's the Centers for Medicare and Medicaid Services. The current director is Seema Verna. She's been in about 2 months now at this point. And then each of your states have a designated state Medicaid agency. It's going to be very important for you, your coalitions, your advocates, your stakeholders to know what that state Medicaid agency is. It's also going to be important to understand that what your state Medicaid agency manages in-house in that department and what your state Medicaid agency engages with other state departments. So many state departments many Medicaid departments will engage with the State Department of Aging for home and community-based services, other resources around that. They will engage with an Office of Behavioral Health, an Office of Mental Health, the drug and alcohol programs for services for that population, et cetera. So it's important to know not just what your state Medicaid agency is, but what responsibilities live with other state departments and how those different state departments work together when you're trying to advocate for a particular agenda, for a particular policy focus, et cetera. And the agreement between the federal and the state government defines the benefits, what services are offered, what services are not, and what's called cost sharing. How much the individuals who receive the services need to contribute. Are there premiums, meaning every month I have to pay a certain amount for my health insurance? Are there deductibles? When I get a particular service, I need to pay some amount of money. Additional provisions are made through state plan amendments and state waivers. And we'll talk about those a little bit. It's important to know all of these, anytime a change happens, there are usually multiple public comment periods, a state-focused public comment period, and a federally focused public comment period, and we'll talk about how stakeholders, advocates can get engaged and comment there. I will move to the next slide. We're talking here about a number of ideas and a number of concepts that folks need to get their heads around as we look into this opportunity. One is the benefits. Each state plan offers different services, different benefits. It's important to know what those are. Each state can make changes at the state level in concert with the Center for Medicaid and Medicare Services. All indications coming from the federal government is that the Trump CMS, the Trump HHS will be looking to give states significant flexibility, which means the states will be able to, relatively speaking, do a lot of different things. Those different things can be very innovative and very engaging for people, or those strategies can make it harder for people to receive their benefits and services. So it's going to be important to look at those options and opportunities and think through. The state Medicaid office has to look statewide and look at a variety of populations. Stakeholders that are working with extremely low-income individuals, stakeholders that are working with homeless populations, stakeholders for supportive housing, all have a very specific lens through which they will consider what the impact these changes may have on their population. And it's really important to be able to educate your state officials in regard to what those changes are, how it will impact your program, how it will impact the people you serve, how it will impact your community. And then we want folks to have the ability to advocate. We want folks to be able to engage in these discussions, and they'll need to understand a lot of the concepts we'll be talking about today. So we're really excited to have everyone with us. it's important to think about the current status of Medicaid under the ACA. For folks that come from the housing world and folks that come from the homelessness world, sometimes this is really hard to get your head around and think about the implications. But what's important to know is that currently under Medicaid, this is a term you don't hear people use much, I hear it doesn't message well, but Medicaid is an entitlement. If you qualify for the service, you must receive the benefit. Because of that, there are a variety of protections and rights and privileges that individuals have. If you don't get the service, you can raise that with patient protection and advocacy groups, things in your state. It's very difficult for those of us who come from the housing or the homeless world because every day we're dealing with many, many people who qualify for the service, but because it is not an entitlement service, they don't receive the service. So Center for Budget and Policy Priorities has done an analysis. 1 in 4 Americans who qualify for rental assistance receive that rental assistance. Healthcare is different. In healthcare, the status is 4 of 4 Americans who qualify and can prove that they qualify receive some type of benefit and assistance. So the basic structures of the programs are very, very different. The AHCA would have took away that protection. The AHCA would have set it up as a program where if you qualify and if there's enough funding, then you can receive the service. It would shift healthcare into much more similar to homeless and housing programs where you have significant numbers of people who qualify but who don't receive the service. It's very, very concerning to many of us. Benefits are extremely different between states. There are very few required benefits, and there are very basic fundamentals, inpatient, outpatient service. There's a significant number of optional benefits, and it's going to be really important that you engage with the experts in your state in regard to your state Medicaid plan. Is targeted case management included? Is a rehab option available? Is my state doing health homes? What's my state doing around substance abuse treatment services? What's my state doing around, this is one of our favorites at CSH, the tenancy support services benefit. Just because it's true in one state doesn't mean it's true in another. Though it's important to know that it could be true in another, and states talk to each other very frequently. They watch, they learn, and we're summarizing, and particularly at CSH, staying on top of the tenancy support services benefit. And we can share details around that. ACA has required the states to shift processes for applying benefits to be a primarily online process. So rather than having to take a client multiple times to a county assistance office, a welfare office, a state office that it signs up people in benefits, it's primarily an online process. What that's allowed is many, many more people who are entitled to the service are able to sign up in services. Research is estimating that about 60% of the people who signed up under ACA were already eligible. They couldn't get through the enrollment process. So ACA gave us some streamlined enrollment protections that particularly for those of us with vulnerable populations find extremely important. And it's also important to know that most of the supportive services in supportive housing would cover under the optional benefit category. So your state's not required to do that. Your state may choose to do that. And it may take some advocacy on your part to get those states, to get certain states to move forward on some of these. A lot of discussion, and one of the big pieces for today is to talk about is block grants and per capita caps. If the HCA was implemented, the federal government would have set an amount of spending for the program based upon past spending and set that amount. It would not be the flexible program today. As we talked about, you'd lose rights and privileges, and it becomes a one-line item in a federal and state budget. That makes it very much easier to cut in future budget cycles. And that's certainly something that we've seen when the TANF program, temporary aid for needy families, went from an entitlement program to a block grant program. States were able to, one, move the money around in many different ways, some of which had a lot to do with the program, and some of which they were stretching it a little when they had tough budget years. Understood, but it was certainly allowed under the new rules. And it's much easier to cut it. It becomes a simple line in a state budget or a federal budget that can be more easily cut. That's obviously concerning us. Two fundamental reasons. The way Medicaid is currently structured, Medicaid rises for two reasons. It rises when enrollment goes up, when more people sign up for the program, it's called a counter-cyclical program, meaning more people need it when state revenues are down. If we think about the recession in 2008 and 2009, many people lost their jobs. They qualified for Medicaid at that point. But state revenues were down. It made it harder to do that. The federal government stepped in and was of great assistance at that time. And then states' Medicaid costs also grow because healthcare costs grow. Healthcare costs grow for all of us. And that's well documented. We'll talk about a little bit about that as well. Let me go back here. Compared to other types of insurance, it's important to know that Medicaid actually turns out to be one of the most efficient programs. Also, Kaiser Family Foundation has done a lot of research on this. They reviewed the literature, assessing a range of evidence on the Medicaid program. The literature shows that per person spending in the program is actually lower compared to private insurers after adjusting for the greater health needs of Medicaid enrollees. So people talk about inefficient government programs. Medicaid is actually one of the most efficient government programs. Medicaid is actually generally more efficient for a variety of strategies and reasons than the private health insurance and the private market insurance that we all likely receive through our employee-sponsored program. A lot of that has to do with managed care and the managed care programs, how the states are running their programs and managing, but it's important. If someone's to argue with you, this is just another big government giveaway and handout, no, actually it's running in a very streamlined manner. Always rooms to improve, opportunities to improve, but it's a very efficient program. Next slide. It'll be important that if the block grants and per capita caps come in, that will end this flexibility. It will end this rise. There will be a set amount of money that the states will receive from the federal government for their program, and if they have more people sign up, the states have to figure it out. If healthcare costs rise, and we know healthcare costs will, healthcare costs have risen every year that we're aware of, healthcare costs rising, the states will have to figure it out. And I want to talk a little bit about some of the concerning state strategies do when they have to control costs. So if the federal amount changes, if the federal amount becomes set based on previous numbers, and states have to save a significant amount of money, or states, let's say, have to contribute a significant more money, states can do one of a couple of things. They can limit the population served. So, for example, a state may say, we're a Medicaid expansion state. Right now we're serving people up to 138% of the poverty level, but the federal government is giving us significantly less money next year. So we're going to make a change. We're going to say that we're only going to serve people at 100% of the poverty level. So all of those people who had qualified for Medicaid, but their income was between 101 and 138% will lose their eligibility, will lose their health care coverage. That's just one example of how a state may say, we don't have the revenue to sustain this program at this time. We're going to have to limit the population served. States can limit the benefits offered. They can put on lifetime caps for money spent, or they can offer fewer services. They can say this service is an optional benefit, and we're going to work with CMS to no longer cover this service, and that will save the state money because we have less federal money coming in to cover the program. If you're working with a person or your program offers that service, that means going forward, the service will no longer be Medicaid eligible. Very, very concerning. States have historically also added requirements that make people not sign up at all. It's important to know that a lot of the cost-sharing work, the having people add premiums and having people have deductibles, very clear research done on this, and happy to share with anyone who's interested the Kaiser family brief on this. States don't save money because they collect lots of, $1 and $2 copays. States don't save money because they get $10 premiums a month or $5 premiums a month from extremely low-income populations. States save money because every time you put another hurdle between someone and their benefits, some people can't jump over that hurdle and some people drop out. So they stop serving people, people stop receiving the health care that they need, and then the states save money. Very, very concerning to all of us, I am sure, on this call. The AHCA actually did exactly something like that. It would require people to re-enroll every 6 months. So every 6 months, you have to go to a county office or sign up online and get your benefits turned on again and prove that you are still entitled to this benefit. You will lose many, many people that way, not because they're no longer eligible, but because that's a hurdle that for whatever reason they can't manage. It's going to be really important if states get the flexibility to do that for advocates for the homeless, advocates for people in supportive housing, to say these are the challenges this puts forward for my population. This is why that would be difficult for people without an address, for people without a regular phone number, getting that paperwork, getting in the mail, saying you have to re-enroll. Keeping that appointment becomes more and more challenging and more difficult for people. States also, if this happened, could, quote, raise new revenue, most commonly called taxes, but that's something that's usually not politically popular and very, very difficult for states to do. So let's talk for a little bit about what you can do. It's going to be important to know your state legislatures, know the and know the chairs of your committees. It's important, just as you've been engaged around the housing and homelessness work in your community, it's going to be as important to get as engaged around the healthcare work. Don't start from scratch. Find out who are advocating for low-income populations, for low-income populations in your state. And a few legislators also often have staff, healthcare policy staff, who are very focused on this issue. Healthcare is complicated. We'll keep saying that again and again. And those are people that you want to understand who they are, what their job role is, build those relationships with, and educate them about these changes and how these changes will impact the people you serve, the programs you run, and the communities you're working with. States are required to have a Medicaid advisory committee. Highly recommend that someone from a housing coalition, someone from your interagency council on homelessness at your state or community, someone who's speaking for people in supportive housing, people experiencing homelessness, people with disabilities, very much needs to join that committee. When states change their Medicaid plans, when they want to do a waiver with CMS, et cetera, there's a public comment period required. Comment, talk about how the changes will impact your program and the people you serve. Once that public comment program is over, the states are required to make changes based on those comments, and then the state sends the state's, quote, final plan into the federal government, the Center for Medicaid and Medicare Services. Then the federal government also has a comment period. Comment again. If the state didn't make the changes you wanted to see in the waiver, comment again at the federal level and say, this is how it will impact my community. This is how it will make it harder for people to get health care or to get housing or to get the services they need. And very much share the stories of improved health outcomes for resident members, with your state and federal delegations at the legislature. Can't overestimate enough how much those stories, how much also engaging with the people who you serve and having them come and speak for themselves, having them come and talk about, here's where I was experiencing chronic homelessness, here's where I am now, I'm living in supportive housing, I'm engaged in my health care, I may be working, and now I'm a tax-paying citizen. That I can't underestimate what an impact those stories have. It's very, very hard. We can refute back and forth on policy. We can refute back and forth on statistics. But when somebody says, this is what my life was, this is the services and supports I received, and this is what my life is now, you really can't argue with that. So those stories and supporting your residents, members around those stories is also going to be extremely important. Another good idea here, find out who's advocating for health care for poor and vulnerable populations in your community. Find out who they are. Create new partnerships with them. Work with them closely. What do they see as key issues? Make sure that they take the time to educate you. A lot of us in the Medicaid space can talk in a very jargony, well, it's not a 1915I, it's a 1915K. What does that mean? What's the implication for the people I serve? What's the implication for my program, my community? Make sure you understand that. Ask a lot of questions. And then stay in touch with all of us here at CSH, National Alliance on Homelessness, and National Healthcare for the Homeless Council for Changes. We will be keeping a lot of this work up to date and working in different ways so whether it's National Alliance's regular weekly email, or it's the mobilizer from Healthcare for the Homeless Council. I'm doing an every other week blog on the implications of healthcare. Again, things can change very quickly. We don't see that right now at the national level, but things also could change quickly at the state. Stay in touch with us, and we will try to share that information with you. And then join us for our next 30 minutes on. We're going to talk about Medicaid expansion, eligible populations, how states think about populations, how they categorize populations, and what that has to do with the work that you all do every day. So with that, I will say thank you. I will put my email in the chat. And if folks have questions, so I do, got through everything, still have a little time. So there is my email. Please be in touch. There we go. Tim had already done it as well. If anybody has questions now, because we have a little bit more time, I'm happy to take them. Did not expect to have time. Okay. Right. Think about the materials. Think about that we talked about here today. Come join us 2 weeks from now, and then also be in touch, and we will be organizing any questions people have. Please also feel free. And the first question we will have, if you say, can I do this in my state, make sure to let us know what states you're from. The answers to many of these questions will be unique state by state, and it'd be a great opportunity to do some research and share some information around what's happening in each of your states. All right. Thank you very much. That concludes the webinar, and we hope you all can join us in 2 weeks to talk about the expansion in eligible populations. Keep up the good work, and we'll talk soon. Thanks.